Yeah, now only it has started.
Sorry, we just noticed.
I just clicked the record and transcribe only, and I thought it got started.
Okay, that was
Okay. Okay. Thank you for letting me know. Uh, mm, so starting, I'm not going to repeat anything anyway. Anyway, aim and scope of preventive and social medicine. So, actually, do you anyone see this recorded version? I'm just
there's
asking you just to know, should I go for a quick review of the earlier, or I just start from here itself because the recording now only started. Just to know that from here, is it okay?
Yeah, I think should be fine.
yeah.
Okay. So the preventive and social medicine, they actually focus on the promotion, the prevention, and overall well-being or the curative. So these are the three terms we can say that is being connected to the preventive and social medicine. Ultimately, when we come into the three particular terms which is related with preventive and social medicine, it is about health promotion, health prevention, and curing. So these become the three pillars. uh, so the aim, as I already told, it is the preventive, promotive, and curative. So starting with the disease prevention, preventive and social medicine aim to prevent the occurrence and spread of diseases in community. So in this, the strategies coming under will be health education, where we are giving health education to the public, the process of immunization. We have the vaccination for each disease, many of the disease, and the control of communicable diseases like the quarantine, isolation that we followed during COVID-19, and even the mask, the social distancing. Then health promotion, it promotes the healthy lifestyle among the individuals and also community, emphasizing factors such as nutrition, physical activity, and mental health. So this is a kind of flies that use for the health education and also for the health promotion. Then sometimes we observe in health sector various days. Most of it we forget, but people who are concerned, like as we have the homeopathy day, we observe these health days so that on that particular day at least we give a session, and also some um, camps are being conducted so that more and more awareness can be given about these diseases. So earlier this session I did for her in the month of September. That is why I kept only September. And this one you can see. So in 1 month itself, now as the batches will go on and the months will change, I will go on increasing each slide about that particular month. So for November, the important health days, you can see how many other, and just by a googling you will understand. So out of this, more important is usually given for the cancer, and also the world diabetes day. These are the two more important days in November that we give importance to. But you can see this much health days, and this is also a part of preventive and social medicine. Like we are giving campaigns, awareness, and also sometimes health screening, just to know whether they have having any prone to develop these diseases, and if they are already developed, then to manage it most efficiently. You can see from this last poll from November 1 to 30, the whole month, it is the awareness month for pancreatic cancer, lung cancer, stomach cancer, and prostate cancer. So just to showing the importance of all these health days, and that all of these are part of the PSM. Then under environmental health, so which is also coming under PSM, we will be learning about the clean water, the sanitation, air quality, and overall environment. The epidemiology, which we did in the last semester, we are going to study about the disease pattern, causes, risk factors, facilitating evidence-based health prevention. Then health education, health policy and planning, because we need the policy from the government also. Sometimes it is not just health education can help us. We need to go for the health policy proper. Over here, okay, not universally also, but I have seen then the people who are driving over here, when they are in the main road, they will be keeping the seat belt out of practice. And even if the first two persons, the people who are sitting in the front seat, if they have not used the seat belt, then a warning tone will be coming from the car. But I have also seen those cars which are going not in the main roads but in the by roads or the interior one. The drivers or the front backs is not, they are not using the seat belt. And the reason once I asked why they don't use the seat belt, it was like, oh, it's not going to come into camera, so it's not a big issue. It's not on the main road. That's the what I got from you. But now, when you go to India, you can see in many of the places in India, it is not yet a mandatory to use the seat belt. In some states it is. So once you cross the border of that particular state, you have to start using the seat belt. And Especially in my state, Kerala, three passengers. Earlier in a two-wheeler, you could even see three passengers. Uh, Excuse me. What? Okay, so this one, what am I saying? So sometimes, yeah, in Kerala. So nowadays, even the pillion in the two-wheeler in Kerala, they have to use the helmet, and it's kind of too difficult for us because we were not using that. Only initially, no one was using the helmet. Then it came like the a driver, the person who is riding the bike, at least he should use the helmet. And nowadays, it is the even the pillion should use. So sometimes health policies are required. Some mandatory rules have to come up to make people, even if they are aware or not, but just make people to do that. Okay, so we need the policy also for the healthcare systems, the disaster preparedness plans, because the disasters, the climate change is now happening and the disasters are happening. So we need to have a disaster plan, everything. So now the two terms that we have seen over here is health promotion and health education. Whether they are same or not, and what is the difference? So obviously they are not same. They are two different things. And what is the difference is health promotion is comparatively an umbrella term, a broad term. This is broader and more comprehensive concept, while health education is just a part of that. So if we see health promotion as a whole tree, one branch of it is health education. So health education is a specific component of health promotion. The scope of health promotion is it not only addresses individual behavior, but also the social, economic, and environmental determinants. But health education, it comes mainly to that individual or to that small community that we are addressing. So we are trying to give them some information, some skills, the teaching skills, or the kind of skills that when we are going to a group of people, like in schools or colleges, we can take some topic, talk upon them. So providing them that information, that skills, raising awareness about specific health topics or behaviors. That is health education. So it is targeted to individuals or small group of people. But over here, the policy things, the economic, environmental determinants, everything is not coming under health education. It comes from the main one, that is the health promotion. So in health promotion, the approaches we have mainly a multifaceted approach. So because there is policy development, advocacy, community engagement, and environmental changes. But in case of health education, it is more involved with structured program. There is workshop, campaign, one-to-one counseling, and more focused on individual or group behavior change. So, for the complete societal change, including the rules, regulations, advocacy, policy development, it everything comes under the health promotion. And health education, it's about changing the behavior, or trying to change the behavior of a group of people or even an individual. So if you are giving someone an awareness about smoking and its bad effects, and trying to convince them how it is bad and how we shouldn't, so that just becomes health education. But when we do it, like the governmental policy also coming up, this should be the minimum age. I'm not sure about the minimum age in Malaysia when you can start using smoking. What should be the age? What is the age, minimum age, to even buy these smoking products in Malaysia?
18, supposedly.
18. Okay, even in India it is 18. So that rules and regulations being coming up. And I don't think in Malaysia there was such a restriction, because I have not seen such a restriction. But I have not gone yet to that much schools also. But in India, um, though illegal things are happening, but legally in India, nearby to school, if they have some shops, the stationery shops, etc., uh, these tobacco products shouldn't be sold in any of the shop in a radius of about 500 to 1 kilometer. I think not 1 kilometer, 500 meters. I think around that school, there shouldn't be any shop that is selling tobacco related products. So these regulations, the policy related, all those will come up under health promotion. And if you're going to a school and say them don't smoke or quit smoking or don't even start smoking, that comes under health education. So, health promotion initiative include the tobacco control policy, improving urban planning for physical activity. So, not just we go and say a group of obese people, not obese people, or generally we go to those people and say, okay, change your diet, etc., and do physical activity. That comes under health education. But doing those things with the help, because if you say them, okay, do this exercise, and if they don't have that facility to do, so what is the meaning? So creating that such a infrastructure, that comes under the health promotion, and advocating for safe working conditions. And in case of health education, the health education classes on nutrition, HIV/AIDS prevention workshop, prenatal education sessions, etc. So everything education related, but policy related, infrastructure changing, rules and regulations, that also comes under health promotion. Then the scope. So the scope is diverse, and it is mainly the community health, kind of repetition of what we did earlier, to identify the health needs, develop the health program, and provide healthcare services at the community level. And in case of Malaysia, there are a lot of national health programs. In case of Malaysia, we have a chapter on that, various health programs that is happening in Malaysia. Then the epidemiology, the vaccination and immunization programs. And this is the immunization program that is currently followed in Malaysia. So you can see what are the vaccines that has to be given and in which month. So this yellow, it is nationwide, and the light green, it's certain states only. So in measles, Sabah only, it is given 6 months. Usually measles has to be given around 9 to 12 months. That's the same thing followed in India also. So 9 to 12 months is one that is followed nationwide, but maybe in Sabah it is endemic. I don't know. Is it like that? Where is Sabah? You know anything about Sabah? Why measles is given only in Sabah in 6 months? Anyone know? I hope you have no idea. So let this be your assignment. Some of you try to find out why in Sabah only the measles vaccine is given in the 6 month. And another one is Japanese encephalitis. In Sarawak, it is given only in the ninth month and a booster dose in 21st month. So what is that specialty with Sabah and Sarawak? That they follow a different schedule for the measles vaccine and also for the Japanese encephalitis. What I assume is if this is being given, these places, Sabah should be endemic area for measles. And Japanese encephalitis is an endemic disease in Sarawak. That is the possible explanation. But if there is something else, I don't know. So I just leave it up to you to find out what is that specialty, why these vaccines are given only in certain states. Then we have the maternal and child health. So whatever sections that you will be learning in this whole the subject or the OM3, you can see over here. So you have one in maternal and child health that is coming under preventive and social medicine. You have antenatal clinics over here. Then also the postnatal clinics are here. The nutrition programs, the child health services, that all comes under MCH. Then occupational health to ensure the health and safety of workers in various industries, health education and environmental change. So PSM, again, the health policy and advocacy comes up. I told you why it is important. And health policy, health equity and social justice. In this only, they also have the insurance policy. Sometimes when we go for the creamy layer or the extreme rich, they won't have any difficulty to access even the expensive type of healthcare. But not every person in every country, even the most developed country, every person won't be having the equal access. Uh, there will be a variation according to their financial condition. So it should be the minimum thing like everyone should have the access to a health care or the health for all concept, which was put forward by the United Nations. So to maintain that social justice, some or the other kind of insurance policy should also be there. And almost all the individuals, not almost all, because it depends upon each country's financial and the infrastructure things. But according to that Health for All of UN, it is told that each person should be a part that health and healthcare access should be possible for him. Just because he doesn't have that much money, he shouldn't be denied a better treatment. That's the principle of the social justice, the health equity. Then the health research, of course, the health research is coming under PSM and the disaster management. Then the social causes of diseases, we have already seen the economic status, income inequality, the framework that I kept earlier, all those things coming over there, education, access to healthcare. Sometimes hospitals may be there, sometimes it is not available, sometimes hospital may be there, but it is not easily accessible to the people because uh, uh, the nearest hospital, the government hospital, may be kilometers away, and there is no particular or a proper transportation, or the transportation, even if there is a public transportation, it may not be maintaining a proper timing, or sometimes the road is blocked, or sometimes if it is more near to the coastal area and very raining, they may not be even, and bridges are not there. So for some time, the people are getting excluded from the main hospital. So whether healthcare service or that hospital is there, that is available, we understood, but whether it is accessible or not, that becomes another issue. And somehow availability is there and it is accessible also. Then they have to see whether the treatment that is being given over there, whether it is being accepted by that persons or not, whether it is according to their culture, their custom, their rituals, or whatever the kind of beliefs that they follow, whether that kind of treatment is acceptable for them. Uh, so for example, it is in a rural area, and suppose there is only a male physician, and a female is going there for a gynec-related complaint. Uh, we may assume, I can't say generalize, but we may assume the doctor is going to follow the medical ethic as such. Without the presence of another woman or a nurse, the male doctor shouldn't examine a female patient. That is the, but just forgetting it for 1 second. I'm just for an imagination only. Medically, ethically, the person is not allowed to do, but just forgetting. And if the person had to do it for emergency, the doctor had to do it for emergency, even though he shouldn't. But he is ready, and he is ready to do in the most decent manner, not seeing it as an objectifying woman or something, in the most decent manner, whether the patient will be ready for that or not, whether the patient will be ready to accept that or not. So that kind of things, that becomes the third. In case of healthcare, when we say the 4 A's come into action, so whether it is available, and if it is available, whether it is accessible, all the people can come or not, and if there are treatment or any mode of management, whether it will be acceptable for all the people in that particular area, and the last one, whether it will be affordable. So these 4 A's are very important whenever whenever you're going to do a project now. And obviously when you're going to if it is a disease, you will have to cover, it depends upon your topic also, how you are going to bring it up. So if it is about some disease in a particular area, you obviously have to mention what about the health sector. And the titles or the subtitles that will be coming, where you have to analyze, will be these factors, whether the 4 A's, whether it is available, whether it is uh, accessible, whether it is acceptable, and also whether it is affordable. Then the kind of social support. Social support will be more about the financial, the insurance policy, etc. But also from the support from the nearby. That sometimes people have got a kind of taboo when they get to know that or a ostracization, that they don't kind of isolate the patient when they get to know that this particular patient has got some serious disease, especially tuberculosis, AIDS, etc. So the kind of social support, occupational factors, housing, discrimination, racism, food insecurity, gender inequality, all those what we saw in the framework in the previous slides. The social and cultural norms. Uh, the cultural and societal expectation can influence the health behavior. For example, cultural attitudes towards smoking, alcohol use, or physical impact activity can impact the prevalence of related diseases. Then the global factors like migration, climate change, political instability, the wars that is happening, have everything far-reaching effects on the health. So one conceptual framework, the social determinants affecting the nutritional status of adolescent girls. So they have gone for the immediate causes, the underlying causes, and then the outcome. Outcome can be overnutrition, undernutrition, vitamin or mineral deficiency. This is just the framework that is usually done or analyzed, especially when it is going for a research related thing, for a master thesis, master dissertation or a PhD thesis, the kind of framework they follow. Now, going towards the problem that is faced by the sick, the social problems. The sick already is in ill health, and he will be having that difficulty, but other than that, the problems. So what I told, the financial strain is the most important one, the hospital bill, medication, therapies. So people may struggle with healthcare cost, especially if they lack adequate insurance, which can lead to financial stress, debt, and even bankruptcy. And people may even sometimes commit suicide out of this financial strain, especially because of their sickness. And there is loss of income because whenever the person is sick, he is not able to go for the job. Sometimes he may have to go to the hospital, which means that there is a pay cut on that day. So there is a loss of income. There is a social isolation, which can lead to loneliness and depression, the stigma, the discrimination, which can lead to shame and lower self esteem. Then family and caregiver burden, because if a person is sick in the family and the person is not at all able to go for the job, then another person have to be a caretaker. So that is going to take the health of that caretaker also, because if this person needs help for anything and everything, even the not sleeping at night to tend the care, so and that person can't go for job, so that is going to add up the problems. Then the access to the healthcare, mental health issues, the housing instability, because these people they won't be able to work and they face the financial difficulties. So it can lead to mortgages and leading to potential homelessness. So the social problems faced by sick, not as nothing related to the diseases. Other than that, the social problems, that is also a lot. Cultural and language barriers. This will be especially faced by the people who are migrators actually. So some people who are coming over here and Malaysia, a lot of people from different countries come, and even me, and then I don't feel that much difficulty because English will be functional over there. But if some uh, people who are working in very low level and they don't know to read English, most of the things will be either in Malay or in English over here in hospitals. And if they're going to go to a clinic, the language can be a barrier. They are not able to say exactly what is their problem to the doctors. Neither the doctor could speak to them what is happening with their body. No, so that that is the social problem met by, and that is what meant by this cultural and language barriers, especially to those people who are migrating. Then loss of independence, when you are getting bedridden, affecting your autonomy. That is depending on someone for their daily task, which is emotionally challenging. And access to social services, like navigating the social services such as disability benefit. It can be complex and time consuming. It depends upon actually the bureaucracy of that particular state. In some countries, I don't know about Malaysia, maybe you can say me if it is very easy to get any disability benefits over here. Is it easier to get the disability benefits? So there is a lot of bureaucracy behind. Is anyone hearing me? Or you
Yeah,
don't
yeah,
know?
can hear. Some of um, I think for some of my family members, so far I see it's okay.
Mhm.
But in general, population-wise, I'm not too sure. Yeah.
Okay. I suppose there shouldn't be as much bureaucracy as we meet in India. And recently, I could say, I mean, I don't know exactly what was happening over there. What is the problem with the papers? I don't know. I just saw in news, and that was actually heartbreaking when we see in the news, and news can exaggerate also. So that is why I can't trust what exactly happened over there. But in the news, the news was like a physically challenged man. He is of 25 years. And physically, in the sense, is a bit mentally challenged also. So he was getting some this benefit every month, and that is like 1,000 rupees. 1,000 rupees means 1,000 rupees in ringgits is 20, 50. Yeah, 50 ringgits. 50 ringgits is what he's getting per month. 50 to 100 maybe. So for the last few months he were getting like few months in the sense years maybe. So in total he might have received all these months 1,000 or 2,000 rupees, counting up to 1 lakh. Okay, so for the first few years, and then suddenly 2 weeks back when I read the news, it was like that. 2 weeks back or 3 weeks back, the notice came from the government that he got the disability benefit, which he was not supposed to get. But the person is actually disabled, okay, mentally and physically, and he is having only an old mother with him, no one else in the home, and they should give back the government that 1 lakh rupee. So anyone for such a family, and he was not receiving 1 lakh what a time. He received like 50 ringgits to in between 50 to 100 ringgits per month for during a course of time. And now suddenly 3 weeks back, the government asking give the cash back. So what happened over there, I really don't know. I did got only this much messages. There can be something political that is involved over there, but this was the situation. So in India, to get a disability benefit itself is so difficult, and then when you get it, things like this also happens. So these are the social problems that the sick people face. Then relation to the economic factors, it is more related to the nutritious food, the safe housing, whether you are living in a crowded house or not, the kind of education that you are having, and nutritious food. Nutritious food, though we all know what are nutritious food, the organic food or whatever, and when we go to the grocery shop, I see that the uh, uh, the food that does that the nutritious food or the food that we assume to be more healthier, that is very very costly when compared to the other type of foods. For example, if you go for the white sugar itself, I think 1 kilo white sugar I get around somewhere in 2 or 3 less than 5 minutes, I think. So, but when I go for the other healthy options, I don't exactly remember, okay. But when I go for this brown sugar or some other varieties of sugar, which is not as uh, problematic as like this white sugar, I see its price is much more than that of the white sugar. So when people who are in a rich people, okay, they may be able to go for this all these organic things and all those things, the nutritious nourishment, whatever the healthier things. But a wide population, they have to almost satisfy with this buying of grocery, which is not that healthy also. So a lot of, even though people know the nutritious food, which are those categories, they may not be able to buy that. Even we go for a bread, the white bread, it comes around 3 ringgits, but when we go for the multigrain, it goes like 6 ringgit or sometimes even above. It depends upon where we are going. So then when the whole family, like if it is a big family and they have to do a monthly purchase, even when they know that it is the whole grain that is needed, that is good for health, still because of this money restraints, they have to adjust with this unhealthier ones. And I always used to wonder why this is happening. I mean, I don't know the policies. The policies. When we go for the drinks also, when we go for the drinks, um, to maybe the alternative methods they are using, maybe Lenny may be able to say because she had done the nutritional course. When we go for drinks, the drinks in which there is no sugar, we have to pay extra for that, more for that. And when there is sugar drinks over there, it will be less cost. But when I think in a normal thing, I mean, I just forget about the mode of preparation or everything. And I see that when we buy sugar, we have to give extra cash. And then we need a juice in which the sugar is not added, then that is more costly. What is happening? It depends upon, yeah, the production, everything that keeping apart. I always feel why these differences are there. Yesterday, now you know this giant is going to close down. So yesterday evening, I just went for a shopping just to see what is remaining in giant now. So I saw just one tin of Coca-Cola. It was a limited edition. I have not seen that anywhere actually. It was also zero sugar, but now I forgot. I should have taken a picture of that. And it was costing, only one was remaining, okay, some were lucky. It was not the other varieties that I have seen. It was like a different color also, and they have given the name that limited edition. Not in giant, but otherwise. So it was, though it is zero sugar, won't be zero sugar. That is another thing. It was costing 5 ringgit, 5 ringgit something, which has been reduced to 4.80, a small tin actually. But the actual Coke, that the red color one, if we go to buy that, it is only 2 ringgits 50. 2.50. So whenever we see the, I won't say that 5.80 or this 4.80 was a healthier thing. The Coke itself is not healthy. But what I'm saying is, when they say the limited edition or whatever, which zero sugar, we have to give for 4.80. But the one with sugar, we have to give only 2.50. So when we people go, they go for the cheaper varieties. If it is actually three or minimum four people in a family, then also to maintain the a budget, majority of the people will have to go towards the unhealthy food, even when they know what is healthy and not. And environmental factors like pollution, clean water. Now going towards homeopathy as a preventive medicines. So we have the level of prevention. Mainly it is primary, secondary, and tertiary. But nowadays, recently they added another one, that is the primordial prevention. Uh, so we see the primordial prevention. Primordial prevention is the risk factors has not yet developed, but trying to cut it out from that particular route itself. We are not even allowing that risk factor to develop. So, for example, uh, we are going to small children, like in a primary school or something, to give a health education. So we assume that this first standard, second standard student and all, we assume, okay, or even lesser to that, they shouldn't get attracted to all these potato snacks, and all the kind of unhealthy snacks that we see different varieties of snacks. The children will be interested in the chocolates in. So even before because all these snacks having chocolates will later result in the development of obesity and other NCDs when they are growing up. So even before to that, even before they are getting practice to such food items, we say them or we give class to them that they shouldn't go for that. So primordial prevention is we are preventing that the development of even the risk factors, which can later result in the emergence of the diseases. It is considered as the highest level of prevention, and it aims to create conditions that promote health and well-being from the very beginning. So even before the risk factors are present, there are no risk factors. Even before that, we are trying to control, or we are trying to prevent, not control, sorry, we are trying to prevent the diseases coming. Yeah, even the we are preventing even the risk factors to develop. That is called as primordial prevention. The primary prevention, the risk factors are already there. What we are trying to do is to control those risk factors. So primordial is there are no risk factors, and we are trying to do, we means the public health professionals, they are trying to do not even allow for the development of the risk factors. And the second one is the risk factors are already there, but we are kind of minimizing it. So in this one, the main example coming under, we can say is in the primordial prevention, the only method, we have methods also. So in primordial prevention, the method that we follow is actually health education, health promotion. Whatever we are saying, that is the main method in the primordial prevention. And in primary prevention, what we actually do is the kind of vaccination. When we are giving the vaccination or immunization, it is a kind of primary prevention. Because why we are giving the immunization? Because that disease is already there. Now we know smallpox. Smallpox have been eliminated from this world. We know that. So now there is no smallpox vaccine given anywhere in the world. Anywhere in the world, smallpox vaccine is not given. So there are no risk factors. That is why even though WHO is storing vaccines, they are storing vaccines, but no, in no country it is being given because there are no risk factors. But then we have the vaccines for the measles disease, and now as we saw, the generally measles vaccine is given during the duration of 9 to 12 months because the children have a risk to develop uh, measles around that period. And actually, before two until 6 months, mostly the mother's maternal antibody that will be enough for the baby to not to acquire this measles. But after that, the maternal antibodies is not enough. That is why the vaccination is being taken. So in case vaccination, why it is happening is the risk factor is the organism, the pathologic, the causative organism is and the favorable environment is that is why we are doing. So that things, the vaccination, immunization, and etc., it comes under the primary prevention. So primary prevention is a fundamental concept in public health, and it focuses on preventing diseases before they become established. It aims to eliminate or to reduce the risk factors. So it comes under three main strategies. One is health promotion. Health promotion also comes under this, like providing education, promote positive health choices, etc. But here the health promotion will be more different, like smoking cessation. So smoking cessation, when we give someone a class on smoking cessation, which means either they are already smoking or the smoking things, that tobacco products are available over there in that area. So the risk factor is already present. So that is why this is not coming under the primordial prevention, but this type of health education in both primordial and primary prevention, health education is the, but the difference is whether the risk factor is present or not. And why I am stressing this much is this can be MCQs. This can come as an MCQ, giving you some scenario and asking you which is the level of prevention that is to be used over here. So that is why you need to know. So in both primordial and primary prevention, health education is the, but in case of primordial prevention, the health education is more related. There is no health risk factors at that time, and you are not even allowing the risk factors to come up. So mostly the kind of people you are giving education over there will be the small children, and the children we don't expect that they have got somehow exposed to the risk factors. But when the risk factors are there, or they have been adapted, or they kind of use it, those risk factors, then we go for the primary prevention. So when a scenario is given, you have to check properly whether the risk factor is present or not, and then decide for it, because there won't be confusion related to secondary and tertiary. Never confusion related to tertiary. The scenario, from that scenario itself, you will very easily understand whether it is tertiary. But always the confusion will be primordial and primary, because especially when we have to ascertain whether the risk factor is there or not, that gets into a confusion. Then specific protection for that particular disease, the vaccination that I told you, it comes over the vaccination uh, for measles or influenza or any infectious disease, that is coming under the primary prevention, because we do the vaccination because the risk factors are already present. So then we don't do it is not the primordial because the risk factors are already present. Then using the seat belt, helmet, condoms to reduce the risk of STI infections, etc. Then environmental and policy interventions. For example, if you're changing the infrastructure so that even people who are having the wheelchairs traveling, so making some infrastructure change for their easy movement, then walkable neighborhood park, anything that is infrastructure change, that comes under the environmental and policy interventions. Then for the secondary prevention is the person has developed disease. So now we have to diagnose it earlier diagnosis and also the treatment. That comes under the secondary prevention. So secondary prevention is a critical aspect, and actually the person has developed the disease. So this one is mainly regarding detecting or diagnosing, and not just detecting, treating the disease also. So at this level, someone is coming to you, like a person with measles is coming to you, and you recognize the patient is having measles. You're not going to say him, the baby or the concerned people, to go and take a MMR vaccine. No, you go for the treatment actually. So that becomes a secondary prevention. So it should be done as early as possible, that it becomes more manageable before they can cause any significant harm. So it is aiming to prevent the progression of diseases and reduce the impact on individuals and communities. The secondary prevention is divided into two main strategies. First one is the screening. The screening that we did in the last semester. We're going into a group of people, testing their glucose randomly, or even checking their BP and getting to know whether they have a high BP or not. The screening comes actually under secondary prevention. So the questions can also be like this: immunization, which is the level of prevention. Now, I'm not going to ask you that question, but I'm just saying the example. And the other one can be screening, in which level of prevention it comes up. So screening means it is to detect the disease, and which level of prevention the detection of disease comes, that's in the secondary. So that is why I'm repeating this much also. So this one, the screening, the diagnosis, everything comes under the secondary prevention. So the goal is to identify at an early asymptomatic stage and to give treatment to prevent the disease from progressing. Examples include mammograms for breast cancer, pap smear for cervical cancer, blood pressure check for hypertension. Then other examples can be early intervention and ART for individuals with HIV, blood pressure monitoring, cholesterol testing to detect hypertension, hyperlipidemia, and the regular screenings for other type of cancer. The last one is tertiary prevention, which is very easy to understand. It is like the person have already have a full-blown disease, but we are trying to do certain things to rehabilitate him so that he doesn't go into a completely social isolation or an exclusion situation. Like for example, in a patient with leprosy, you have learned leprosy, and you know in case of leprosy, after years, it is a chronic disease, and after years, they are going to have mutilation. The fingers may be lost, even the nasal, this oropharyngeal, the bridge can be broken. So even the nose will be getting drawn in, that shape may be going. So all these changes, even blindness may develop. So once you recognize the patient is having leprosy, then give him the treatment, not just a treatment, but the kind of rehabilitation so that he doesn't go into a bedridden situation. So tertiary prevention is minimizing the impact of established disease or disability and preventing the progression and complications. So unlike primary prevention, that is preventing the disease from occurring, secondary prevention, which is detecting and treating diseases early, tertiary prevention aims to improve the quality of life and reduce the long-term effects of diseases, especially for those individuals who are already affected. So the strategies coming under there are cardiac rehabilitation program for individuals who have had a heart attack, pain management program for individuals with chronic pain conditions, speech therapy, palliative care services with advanced cancer. So there is a framework for the levels of prevention. The primordial prevention, where we are saying even before the development of the risk factors, the general health enhancement measures. The primary prevention, risk factors are those, so the specific measures to reduce the risk, especially the vaccination and infrastructure change. The secondary prevention, regarding this primary prevention, I made a mistake. That is why I'm saying I attended one of the exam, and in that the question was something related to infrastructure change actually. I wish I wrote this exam after to the classes actually. Anyways, it was about the infrastructure change. So I was so confused whether it is primordial or primary because infrastructure change. I was like, okay, the risk factor is not developing. Uh, a kind of like the people are already walking, so there is no risk factor developing. So it should be a primordial, and I put primordial, but the infrastructure changes anything, it will come under primary prevention. Uh, then the secondary prevention, it is about the early diagnosis and treatment, and tertiary, which is about to prevent the complications and disability. Now, going towards the section 15, that is the homeopathic concept regarding prophylaxis. So, what we have the concept about preventing the disease. Prophylaxis is prevention. So, in homeopathy, prevention primarily revolves around the use of constitutional remedies. We don't have this primary, secondary, tertiary. That is more of a modern medicine concept. And why I gave importance is because of the MCQs that is being asked and how we can get confused and just mark the wrong thing. That is why I can explain that. But when we come into homeopathy, we don't have, we don't, according to the homeopathic principle, much of this primary, secondary, primordial. We do like that. We do give a health education. We unknowingly, as a part of our life, being in a medical profession, we do like that. The primary, secondary. The tertiary is not coming under us. Tertiary is usually going to the physiotherapy section, but the primary, secondary, and the primordial, it is in our hands also. We can do, but strictly going to the homeopathic principles, what we think about the prevention. So it is around the use of constitutional remedies and individualized treatment based on a person's unique constitution and susceptibilities. So the constitutional remedies, that we take the person as a whole, his mental, physical, and emotional aspects, and also give importance to his vitality, immunity, and it is believed that our medicine will enhance his vitality and immunity and reducing the likelihood of falling ill. And when we go for this, even in the organon, I think it is in the FRS 4 and 5, Hahnemann has given importance to the environmental factors, the situation in which he is living, working, people around him, the diet, all these things, and Hahnemann have mentioned already, not in fourth, I think it is in the fifth, he has given importance, the environmental factors. And like before selecting a constitutional treatment or a medicine, we have to consider all those things he have already mentioned over there. Then we have the mathematic theory. This is also considered as a mode of prevention. Homeopathy also consider miasm, which are inherited predisposition to certain diseases. Miasmatic remedies are prescribed to address these underlying tendencies and prevent the development of related diseases. Sometimes you could see that if there is a history of cancer, the doctors, when they are prescribing, not just the history of the patient, even if there is a family history which is very prominent, like 3 or 4 people in the family have a cancer, then they maybe will be giving more importance towards a psychotic treatment or a psychotic antipsychotic remedy for the patient also, considering that there is a psychotic mechanism that is lurking behind. Sometimes it may be a carcinosin or medorinum. So sometimes even the mechanism we give importance when we are going to prevent the diseases. Then we have prophylactic remedies, like many preventive medicines we have got. One of the most famous is variolinum. And I don't know whether I have told this story before, but once I was working in 2016, 2017 around in Trivandrum in a public health project, and that was related to diabetes mellitus. Okay, and we were not giving any treatment in that project. I was the quality control manager, and we had to go and give health education to group of people. So those were our subjects because it was a research study that was all earlier planned and decided group of people. So, but we were never giving them anything regarding to diabetic treatment, no medicines, neither allopathic. It is a allopathic hospital, okay? It is a allopathic hospital, and they had a public health research wing. So I was working over there. But this project, they were never giving any medicine to the diabetic patients, and what we were doing was giving them the the classes regarding their diet and also the physical activity, and then the people, especially males, if they are having smoking and alcohol, to quit that. So that is what our classes were mainly. So had to do classes for 12 months and then go for after the classes or the project. So we had a before after, what is the change being done. So that was the project about. So nothing related to homeopathy. That's what I wanted to stress about. But that was a allopathic hospital. So one day I was on leave, and the next day morning, I reached there, and my colleague told that the day I was on leave, allopathic doctor, I mean, a doctor over there, a medical doctor, he's also in public health research. This is a public health research wing, actually. This doctor had come to, he came to my office asking whether I'm present or not. So when they told that I was not there, he just left. In that office also we had a timing like 8 to 4 and 9 to 5, something of that sort. So I was in the 8 to 4 slot, 8 to 4 or 8 to 5. Now I don't remember. Anyway, that slot. So I got this news by 8:10 or something. The moment I reached there, and but I was not sure this particular doctor. I know that person, but I don't know what was his timing, whether it is 9 to 5. I don't know. So I thought, okay, for a safety, I will go after to 9 to his office. Just so anyway, after to 9, he should be there. Even if it is 8 to 4, his timing is, or 9 to 5, he should be there anyway after 9. So I thought, okay, I will go to his office after 9 to see what's the matter. But then by 8:30 around, he again came to my office. So he was quite senior. So I felt a bit embarrassed. Okay, I should have gone earlier and asked, because making him come a second time. So I asked him what was the matter, and what was the matter was he wanted to get the prescription of variolinum, and he didn't know the name of the medicine. He just told me, "You people have a." So he know that I'm a homeopathic doctor. So people in homeopathy, there is some medicine to prevent chickenpox. Because a day before yesterday or something, he already had an exposure. So yes, the previous day, that person with whom he was exposed, they had this chickenpox eruption. So now he wants to take that medicine. So I told I don't have the medicine. I told prescription is enough. He will buy. I gave the medicine and the prescription, and I told, sir, I'm almost sure. Even after you're exposed within 1 to 2 days, this being taken is should be working. But still, in case, because the 2 days have already passed, so still in case, I don't know. Then he told, oh yeah, he knows that, but still just give the prescription. So I gave him the prescription, and even before me asking, maybe from my facial expression, he got my question that how he knew that we have a preventive for chickenpox. How he knew? I just looked at him. I didn't ask. Then itself he told that during his college days when he was doing MBBS, at that time, someone in that medical college developed chickenpox. And I felt it's so strange at that time because this was happening in Kerala, and he was studying in no, sorry, the government medical college in Kerala in Trivandrum. So it was quite senior also. So I was thinking, oh, years before that happened in a medical college in Kerala, not the homeo, but the typical MBBS medical college. So chickenpox became an epidemic, and all the students were asked to take um, this preventive medicine for chickenpox from a homeopathic prescription. Like they were asked to meet a particular doctor. I don't know how the medicine was given, but they were told to take this medicine, and the chickenpox didn't get spread. I mean, it stalled over there. So from his MBBS days itself, he knew that this medicine, homeopathic preventive for chickenpox, works, and that is why years later he came. He didn't know the name. He came to me and took the prescription, Luckily, he didn't develop also. Okay, so we do have our preventive medicines for many of the conditions. Variolinum, I just told the story, but we have the measles, morbillinum, then parotianum. Mostly the nosodes. That's coming under the another section, the nosodes. So we have these prophylactic remedies. Remedies like Arnica montana can be used for preventing bruising, but there is no use. I just put that what I saw in the literature. But even bruising, if it is only too much pain, we need to give arnica. Otherwise, just leave the story off. It will, because the body will get just itself as adjusted in 1 or 2 days. Then going to nosodes. Nosodes are homeopathic preparation made from diseased tissues or secretions, and most of our preventive medicines are actually nosodes, even the variolinum. Then hygiene and lifestyle. Hahnemann often advised on maintaining a healthy lifestyle. He had even given us direction what to eat, what not to eat during proving, during taking medication. Everything he had laid out in literature correctly what to eat, what not to eat. But then his diet is difficult for us to follow because he is mainly explaining about a typical European diet, which don't follow exactly. But then we can avoid those things which are too spicy, too addictive, etc., making it much possible. But then too, uh, uh, now we give more importance to this food nutrition, what is to be eaten, what not to be eaten. Just a Google search will give us a lot of information, but this thing was stressed by Hahnemann even in the 19th century when modern people were not giving much importance to the food and nutrition. He had given importance to the nutrition, exercise, the stress management. To support stress management, of course, in his chronic diseases, I think he had given um, and also in organon of medicine, while drug proving that the person should be away from the stress related matters or occupation related matters. Uh, so he had given importance to the stress relief or to be avoided from that, which means even at his time he has given all these the health lifestyle importance too for the disease prevention and overall well-being. Now, the second concept of homeopathy regarding the vaccination, this was given by Irwin Lodon. So, about vaccination, Hahnemann, what he's believing. So, just go through that. Hahnemann believed that if a patient had an illness, it could be cured by giving a medicine, which, if given to a healthy person, would produce similar symptoms of that same illness, but to a slighter degree. Our similar is curanter. That's the principle they're saying about. So, if a patient was suffering from a severe nausea, we give a medicine which, in a healthy person, would provoke mild nausea. By a process he called proving, Hahnemann claimed to be able to compile a selection of appropriate remedies. This led to his famous aphorism, like cures like, o similia similibus curantur, which is often called the principle of similar. And he cited Jenner's use of cowpox vaccination to prevent smallpox as example. Quite significant was this comparison. Now, 1 second. Okay, this one, this law, the similar similibus curantur, this is actually nature's law. Uh, the like cures like, but the homeopathic principle, it will be curantur. Let likes be treated by likes. That's the difference. Should keep in your memory, okay? because this is someone's statement, I cannot do anything. And actually, like cures like is actually the nature's law, the similar similibus curante itself. But homeopathic law is actually let likes be treated by likes, or similar similibus curante. So this was just to say that Hahnemann had cited about Edward Jenner, who was the first person to use vaccination. And we had studied this history in the last semester also, how he used the cowpox vaccination, because cowpox was comparatively milder, and he had noticed that people who develop cowpox, they don't develop smallpox. So he took, when one of the patient developed cowpox, from that patient's discharge, he made a kind of vaccine. Now I don't know the preparation. We can just say that he made a preparation out of that discharge. How he made, I don't know, or diluted, I don't know. And then he gave to a boy who didn't develop smallpox in later. So that was the history of how this vaccination was first brought up. So Arvin Luden has told that even Hahnemann have compared that cowpox vaccination to prevent smallpox is almost following the same principle as like that of homeopathy. And when we go to the Hahnemannian concept, you can see that Hahnemann was convinced to the effects of vaccination for the eradication of smallpox, especially the evidence from the experiments of the Dr. Edward Jenner. And in fifth edition, he has mentioned that in aphorism 46, and sixth edition of Organon, he had mentioned that in the footnote of aphorism 56. Now, when we read this, we just come into a confusion like we don't accept vaccination. Basically, homeopathic doctors are against vaccination. Then how come our own master Hahnemann had accepted vaccination? But I would like to say that what happened was at that time, what Jenner did was what Hahnemann did. We also do something like that principle. We go for the milder one, not the exact similar. We go for the similar thing, but the milder than the what is that? Uh, if the disease is stronger, we actually give something stronger, but similar thing, not the isopathy. But when we think like this, when we consider what actually Edward did was, Edward Jenner, had he given the smallpox patient the discharge from the smallpox patient itself as the vaccination, then that was isopathy. Then Hahnemann might have questioned it. But during Hahnemann's time, what Edward Jenner did was he took that vaccination from a comparatively less dangerous disease than smallpox, the cowpox one, and then gave it to the prospective, not the patient actually, the another boy who never developed the smallpox. So he was going to the similar but weaker principle, almost similar to that what Hahnemann was propagating about. So that might be the reason Hahnemann accepted the vaccination principle of Edward Jenner, because it was not equal to equal or stronger, but the vaccine was actually taken from a disease milder but similar to smallpox. Maybe that was the reason Hahnemann accepted. But later, the concept, the vaccination completely changed. Now it became from the same bacteria, and then either killing it or live and attenuating it. So the principle has now completely changed. But during Hahnemann concept, Hahnemann's time, it was Edward Jenner who did it for from the cowpox for the smallpox, which was similar but weaker, and hence he gave that similarity, or he supported this idea. Then regarding Herring, Herring in 1830 suggested that the prevention of many diseases can be done by their own morbid products, like the saliva of a rabid dog might be prophylactic for hydrophobia or rabies, but I don't know how much it will be working. Then post-Hahnemannian concept, Dr. Burnett, he came up with the book Vaccinosis, and he was against vaccine. He told that the vaccination can profoundly be disturbing, and produce lasting effects on the effect of the susceptible individuals. This we are always almost hearing that it can affect our susceptibility. When a baby is born, we don't know whether that baby has a natural susceptibility to measles virus or not. We really don't know. But still, we are giving nowadays this measles vaccine for the baby. Now, whether the baby is susceptible or not, we don't give importance, not we, the health professionals, the modern medical professionals. But that is what is mentioning when we are giving that vaccination. So, if that baby didn't have the susceptibility to develop, not everyone who is taking birth here are developing measles, not like that also. Some are susceptible, they will be developing, some are not, but we don't know. So when we give that vaccination, we are changing the susceptibility of that patient, the natural born susceptibility that we are changing. That was the concept of Burnett. Many cases are dramatically benefited by the administration of potentized preparation of the particular vaccine use. So he was mentioning if we also have to go for a potentized preparation. Then Stewart clause, vaccine creates only a spurious immunity with destruction of the normal susceptibility, somewhat similar to what I told earlier, it is affecting the normal susceptibility, what Bonnet also told, and it is creating a kind of spurious immunity towards that. It's doubtful. Maybe the child naturally wouldn't have developed measles. But by giving that vaccination, we are changing that susceptibility, and the baby is having a skeptical or spurious type of immunity towards that. It sets up a morbid condition instead of a healthy one with degeneration of the physical plane. And comparing the vaccination to isopathy that was done by H.A. Robert. So using a diseased tissue is isopathy and not homeopathy. And this vaccine is not an example of the law of similars in action, but the law of identicals or isopathy. So nowadays we are actually following this because during Hahnemann's time, it was cowpox. As I told you, it was similar and weaker that was used for a vaccination purpose, but that is not the process that is followed post Hahnemannian. It is actually isopathy. They are taking the same organism and then either killing it or kept it alive, but reducing its disease-causing property. So it is isopathy actually, the law of identicals. Then regarding Dutton was like he didn't go for the vaccination. He was like the first vaccine that was not actually Edward Jenner's, but he believed that it was the Dr. Hahnemann's preventive for scarlet fever, that is belladonna. It was the first vaccine. That's what he was mentioning about. He reasoned a remedy that is capable of checking a disease at its onset must be its best preventive. Then regarding the concept of George Vithoulkas, he was always against that. In his Science of Homeopathy, he's saying that without considering the individuality, the concept of vaccination is exactly opposite to the principles of homeopathy. So that's the concept of George Vithoulkas. Even if it is for a vaccination, he says that give importance to the individuality. If the individuality is not concerned, and nowadays in vaccination, no individuality is concerned. Every baby who is born, hospital born, obviously they have to take the vaccinations. And at my time, I was born, I remember it was more of an optional kind. If the parents want to give, if it is hospital born, yeah, at that moment itself, when I was born, I was given the TB vaccine or the what is that, BCG. But other things were optional actually. Though my family, my parents have given me all the prescribed vaccines according to our national immunization schedule. But now I see. Uh, but there were options. If parents didn't want to take vaccinations, they could skip it, and it was not a problem. But nowadays, I see the schools have made it compulsory that the a health card will be given when the child is born, or even the antenatal time. And when the child is born, the vaccines, what all vaccines they have, the baby has taken, including the booster doses, they will be putting a tick on that. And when the baby is going to be enrolled in a school, they are supposed to submit this vaccination card also. So this vaccination card, when they first the nurse give to the mother, and the first vaccination is being taken, they will be saying that, see, you have to show this for years, because when you enroll this child to the school, you have to show this card actually. uh, so nowadays in India, you for in some I don't know whether it is universal in all states, because there may be villages it is not necessary. I'm not sure, but in my place, if we have to enroll a child to a school, we have to show that vaccination card, that minimum national immunization schedule, that 9 vaccines that have been taken. Otherwise, no enrollment is given. So it is a kind of putting upon a mandatory kind they have to do. Then this is some examples. It's not the concept of George Witholker's. I should have kept a uh, gap over there. The treatment for vaccinosis. This should be another title. So some of the medicines for the vaccine, bad effects of vaccines, we have already learned, like antimtot, belladonna, mesarium, sarsaparilla, silesia, for the bad effects of vaccination, thuja, and so many, sulfur, melandrinum, variolinum, protalus horridus. Just as indication that you can read by your own. So we have so many medicines for this vaccination complaints. And this sentence, if the patient says, I have never been well since I have vaccinated, then we first think of Tuja. This could be you keep in your memory, because a lot of people do say problems. Sometimes it may be related, sometimes it may be unrelated, we don't know. But many people say they started such a symptom, or they had an aggravation of such a symptom after to the COVID vaccine. Now, the third concept is about immunology. So immunology, it is the immunity, what they are saying about. So we believe that the homeopathic medicines are strengthening actually our immune system. So therapeutic methods that strengthen a person's immune or defense system has a long-term benefit and can prevent recurrence, but the benefit is sometimes achieved more slowly. In addition to have effects on a person's immune system, research described in a respected pharmacology journal that homeopathic medicines have a significant effect on gene expression. And that was actually given by Dana Ullman, MPH. So in one of the European Journal of Pharmacology, they have given that homeopathic medicines are thought to stimulate the body's own defenses. For example, silesia, it stimulated macrophages, and macrophages are very important because they are the main phagocytic cell. They help in the phagocytosis of the bacteria, the debris, and other foreign materials. And it's actually an important body immune system part of it. So silesia is seen to stimulate the macrophages, but how or why silesia is able to do this, it is unknown. Also, that how these medicines are acting on our body defenses, that remains a mystery. And not just stimulating, our medicines are equally effective to calm our immunology or immunological process. That is why our medicines can be given for autoimmune diseases also, like rheumatoid arthritis. Our medicines do have a calming effect, because it is not just the stimulating property we have, but the calming effect also. A study on 46 people with RA showed that those given individualized choice of homeopathic medicine got considerably more relief than those given a placebo. So in that study, 82% of people, like they had a relief from pain from homeopathic medicine, while with a placebo, only 21% has got a similar relief. So as Jonas Sack noted, instead of trying to attack a specific problem, another strategy is to re-establish health to stimulate a person's own immune and defense system. And that is what exactly the homeopathic medicines are being done. And this is something about the history. It's actually homeopathy gained its popularity in Europe and America during the mid and late 1800s, primarily by achieving success in treating people from infectious diseases, especially cholera, typhoid, yellow fever, scarlet fever, mainly scarlet fever and cholera. These natural medicines were not effective because they attacked the infective agent, but because they stimulated body's own immune and defense system to defend and heal itself. Actually, what we did during our, practicals last time, none of our medicines, I just got injured. I didn't send you the picture also, right? Because there was no change. Actually, I was a bit depressed when I saw we actually put the HEPA calcarea sulfur, all those 6C, I could just see some a bit change with the echinacea tincture, but with no other potency, there was no change. So it is not the infective agent that getting attacked or something. It is not antimicrobial our medicines are, but what they do is actually stimulating the body's own immune and defense system so that it defend and heal itself. Then the last concept is about personal hygiene. So its aim is to promote standards of personal cleanliness within the setting of the condition where people live in. And personal hygiene includes bathing, clothing, washing, keeping the care of nails, feet, teeth, etc. The training in this field should begin at very early age and must be carried throughout the childhood. So about hygiene, Hahnemann has given importance in this book, The Friend of Health, where Hahnemann has given importance to the use of fresh air, bed rest, proper diet, sunshine, public hygiene, etc. And Hahnemann says the physician is not only a healer but also a preserver of health. And he mentions this in aphorism 4. In aphorism 4, he says about preserver of health. So the mission is not just curing the sick individual, but also to prevent the patient, the people from becoming sick by guiding on sanitation and hygiene. A physician can fulfill his duties completely. So Hahnemann, in Friends of Health, uh, So in that book, Hahnemann has advised that after every visit, the doctor should wash their hands and faces in vinegar and water. And if he requires to feel the pulse, he must do this with averted head and immediately afterwards wash his hand in a basin containing water and vinegar. So, friends, a friend of health as pioneer is considered to be the pioneer of preventive medicine. And here he has given many instructions regarding the public health and also personal hygiene, stresses upon the importance of cleanliness, anti-infective measures to be adopted in the town among the doctors and nurses, advises to avoid things which can pollute the air, dampness, excessive fumigation, etc. Give special attention, he means Hahnemann, to the problems of town life, upbringing of children, necessity of exercise and fresh air. This was the first book written in a simple style on common subjects of hygiene, which could be read and utilized by the patients as well as physicians. And continued regarding hygiene, another person mentioned about this Carol Dunham. So when we are living in unhealthy surroundings, eating improper food, leading a disorderly life, it becomes a fertile base for the germs to develop. So he has given something importance of to hygiene and also therapeutics, and he believed that a physician should be at the same time hygienist and therapeutic. So therapeutics, he says that it is about the remedy, the medicine which we are going to give the individual case, And hygiene is actually what we have to practice the environmental and around us. So um, that insofar as hygiene is concerned, the practicing physician is at one and the same time hygienist and therapist, employing often. Therefore, for the same case, both specific remedies and also various auxiliaries. Various auxiliaries will be this coming under the hygiene. So it is only the therapeutic that we and allopathics are getting differed, where the remedies are differing. But when, as far as hygiene is concerned, we homeopaths and also allopathics have the common ground. And this is activity, the quiz time that was just kept for the MQA purpose. If you want, you can go through it later when you get the PPT. Can someone take a screenshot, or already has it been taken? Oh, wait. Let us stop the recording.